Thank you very much, Simon, and thanks to the Yorkshire Society. Nice to see your new hairdo. Yeah, what he didn't realise, of course, was the abbreviation for time for first flatus. He didn't read the full paper, and the abbreviation to time to first flatus is. Now, what's going on is the presentation is now at the back of the room, and I'm at the front of the room. We've had some problems. My presentations run very fluidly and smoothly because I advance the slide invisibly every 2 or 3 seconds, so you hardly notice it. Except now, every time I advance the slide, if this button works, it'll be fantastic, and it doesn't. So I'm going to have to go like that every time I want the slide advance. So, and I'm going to be waving my arm in the air now, a hell of a lot. And when I go like that, you advance the slide. Like that. That worked well, didn't it? Are you doing it? Can you advance the slide then, please? Oh, thank you very much. Okay, so every time I wave my arm in the air, there's going to be a lot of waving. You got it, Asim? All right, good. So some health warnings first of all. I'm going to talk about my medico-legal practice, and I do indeed derive some income from that basis. This is just the database of a single anaesthetic expert. It's not triangulated in any way at all, so what I say isn't necessarily what judges think, or indeed whether something's negligent or not. Some of the cases I may describe that are still open. If you recognise any of them, just walk quietly out of the room. There's an average 3-year delay between cases occurring and them coming to the attention of any expert at all. I've got no information as to the outcome of these cases, and I have anonymised and digitised, disguised them wherever possible. This is good. And there's going to be a lot of this. So here's the next one. If you're going to prove somebody negligent, you have to show that you have a duty of care towards them, that you have breached that duty of care, that they have suffered an injury, and that there is a direct causative link between the breach of duty on the one hand and the injury on the other. So, the test for breach of duty is a simple one, and not a very highly set one either. The Bolam principle, said a very long time ago, in fact I think in the year that I was born, which is a very long time ago, shows that you're not guilty, and for doctor, read midwife, or anybody else, if you've acted in accordance with a practice accepted as proper by a responsible body of medical opinion, let's say medical opinion, not medical men, just because somebody else will do it differently, as long as there's somebody out there who will support you and say, yes, there's a responsible body of medical opinion that would have done it the same way, you're okay. It's not a very high standard at all. And it's been recently modified by the Belitho test, which talks about the body of opinion. So the body of opinion to be accepted by the court, it's got to be responsible, reasonable, or respectable, and has to take into account the question of comparative risks and benefits in doing so. So it's now not quite as straightforward as it was. It's no good coming up with a completely ex-cathedra, off-the-wall statement saying, yeah, the bunch of anaesthetists would have done it this way. You have to be able to defend that on those grounds as well. Don't wave your arm in the air. So, here's essentially, if you want a single slide guide to negligence, this is the one. So, here's the questions that people will ask if a patient thinks you've been negligent. First of all, have you practiced in accordance with a reasonable peer group? If yes, that's the Bolam test. Then the Belitho test, is it amenable to logical analysis, if you like? If it's amenable to logical analysis, you're fine. Your duty of care is fulfilled, it's an acceptable legal standard, you're clear. If, however, the answer to either of those is no, your level of care is unacceptable, it's unacceptable legal standard, and you have failed in your duty of care. But that's not the end of the negligence case, because then, is there a direct causative link? If not, however bad you've been, if there's no direct causative link between your breach on one hand and the injury on the other, you are not negligent. You're only negligent if there is a direct causative link. And that's it. That's the whole of negligence. That's what myself and the next speaker get paid large amounts of money to do. If only it were that simple. So this is Bogey's Legal Obstetric Anaesthetic Database, B-load as we now call it, from 1994 to 2014, 21-year experience of some 750 cases. And to think that's a lot, Derek Tufnell, who's speaking after me, some 3,500 cases. 3,500 cases! Of mine, 367 are obstetric and the rest are not. Doesn't mean that half the claims brought against anaesthetists are obstetric claims, it's just that happens to be how many I've dealt with because I'm an obstetric anaesthetist, so it's about half. And these are the common factors that run like a golden thread, to quote Rumpole, through negligence and obstetric anaesthesia, and I'm quite sure everything else as well. If I was to pinpoint the three areas where we fall down and where a failure in one of these three areas is sufficient to tip something into a claim for negligence, these are they. And you can see communications and record keeping are right up there, and consent, about which Derek is going to speak more, is another big one as well. It's like he anticipates my mood. It's fantastic. That seems amazing. It hasn't changed over the years either. If you divide my 21 years into 3 7-year groups, it hasn't altered. In fact, if anything, communication and records now feature more strongly than they used to when I started out. But they are recurring things. If you get those right, actually, generally speaking, you can get away with bad practice. That's not what I mean. What I mean is you're less likely to get sued if you communicate well and if your record keeping is good. What proportion of the cases that have come before me in obstetrics do I think there's been some negligence? Well, not many actually. I think in 46% of cases, nearly half, I don't think there's a failure of duty in the first place. In another 16%, I don't think there's a direct causative link towards any injury the patient has suffered. It only leaves about a third in which I think there may have been a successful claim for negligence. Doesn't necessarily mean they will succeed, but that's what I think's about right. And this is quite interesting as well, because if you look at all the cases that I've dealt with over the years, and you take away the ones that are non-specific, you're left with two groups. And the group on the left are the regional anaesthetic cases. You can see they incorporate a number of things, pain during caesarean section being by far the biggest one I deal with, headache, backache after epidurals, neonate because, as Derek will talk about later, there's often an anaesthetist included in claims for neonatal hypoxic ischemic encephalopathy because you failed to get the patient to theatre fast enough, or if you got to theatre you failed to deliver the baby fast enough, and that's sometimes down to the anaesthetist's choice of anaesthetic technique, and various block problems. And the other little group on the far side are the general anaesthetic claims. And actually, you look, they really make up a very small proportion of the claims related to anaesthesia. There's a bunch of stuff in the middle as well, which is neither general or regional. But we always think of general anaesthesia as being hazardous, and it is more hazardous, of course, to the mother than regional anaesthesia. And those claims, particularly the ones for airway problems, lead to very severe harm, of course. But it is interesting to see that there's such a large number of claims related to regional anaesthesia. And it's not all down to the fact that we give a lot of regional anaesthetics, because this database started in 1991, 92, where at that time nearly 50% of caesarean sections are being done on general anaesthetic. They've only changed. In my lifetime as a consultant anaesthetist, that's changed very dramatically, as you can see. So if we look at all cases, we'll get rid of a few groups like that. Look at the big five. The big five vary tremendously as to the proportion I would regard as negligent. So at one end of the spectrum, backache claims. Backache claims never succeed against anaesthetists because childbirth causes backache. Epidurals, statistically speaking, don't cause backache. And even if you put an epidural in and a patient gets backache as a result of the epidural, it doesn't mean you've done anything wrong. So only 7% of those cases I think there's any degree of negligence at all. Whereas if you look at the other end of the spectrum, pain during caesarean section, at 75% I think there's been some negligence on the part of the practitioner. That really isn't. So pain cases make up 20% of my medico-legal database, but 40% of cases where I think the anaesthetist might have been negligent. It's by far the biggest successful claim against anaesthetists in the UK. So we take the big five, we'll get rid of neonatal box because Derek's going to talk about that. We'll get rid of backache because backache claims never succeed. We're left with those three. I'll throw in a quick hemorrhage case as well, and we'll talk about some specifics in those areas. This is working. I'm going to take Asim with me everywhere I go. This is fantastic. It's very good. Okay, so what pain during caesarean section? What causes pain, or what's the associations of pain during caesarean section? As you can see, the vast majority of cases arising from pain during caesarean section are related to epidurals, not to spinals, not to combined spinal epidurals. And actually, if anything, that's got worse over the years. So it's now 62%, I think, of all cases of pain during caesarean section relate to epidurals, not to spinals. And that's not, again, because most of our caesarean sections are done under epidural, because they're not. And if you look at the data there from the recurrent National Obstetric Anaesthetic Database figures, you can see that it's pretty consistent. 20% of our sections are done under epidural, but they account for 62% of claims for pain. So there's something special about epidurals, without a doubt. So here's a typical sort of case. Category 2 caesarean section patient, reasonable pain relief from her epidural originally in labour, but then it doesn't get quite so good, and the pain relief starts to wear off, and that's quite a common feature in these cases. A standard sort of top-up, an indecipherable record of the block. I still don't know what C-710.7 means. Nobody's been able to interpret it for me. It's quite clearly written. No one knows what it means. It doesn't tell you where the upper level of block is, unless the upper level of block is C7, but it still doesn't seem to make much sense. I don't know what the 10.7 is. Procedure stopped 7 minutes after the incision because of pain. Induction of general anaesthesia 9 minutes later. Delivery 2 minutes after induction of anaesthesia. Vital signs stable to and up to, and including induction of general anaesthesia. That's quite a suspicious thing, I think, on an anaesthetic chart. If you've given somebody, if someone's had a lot of pain during a caesarean section, and you've given them a general anaesthetic, and you put a tube down their throat, and through all that period, their heart rate hasn't moved one iota, even during and after the intubation, it does call to mind a faint suspicion that the chart might not be entirely accurate. And there's no comments on the chart as to why the patient felt pain, or why general anaesthesia, or whether the patient felt pain, or why general anaesthesia was induced. So we're left a little bit in the dark with a poor record. And this is what the patient and the partner said, and of course the patient's always supported by a partner in these cases. She said that when we ask her how the block's been tested, because that's where most of these claims succeed, is in poor testing or poor record of the block, tested with an ice cube on the abdomen, said she could feel it was cold right down to the umbilicus, had pain from the first incision, and she had pain immediately post-operative, which suggests, again, a poor block. You give a general anaesthetic, you wake them up at the end, and they're in significant pain at that point. It was probably quite a poor block to begin with. These are the features, the sort of features that crop up in these cases over and over again. The patient hasn't been warned about the possibility of feeling pain. They've sometimes been persuaded away from a general anaesthetic, often for no good reason. One of the cases I dealt with just defies description, really. She'd had 4 previous caesarean sections under regional anaesthesia, every single one of which had needed supplementation. She had 1 general anaesthetic induced during the procedure, 1 general anaesthetic induced before the start of the procedure because the block hadn't worked, 1 of them supplemented with entonoxin alfentanil, and 1 of them supplemented with ketamine. She came to her 5th caesarean section. She had a known placenta accretor. She wanted a general anaesthetic, but the staff grade anaesthetist persuaded her to have a spinal anaesthetic. He used 2 mils of heavy bupivacaine, and surprise, surprise, she felt pain during a caesarean section. I cannot for the life of me fathom why that happened. You know, what was going on in that anaesthetist's head that he thought that was a good idea. Perhaps it's a bit of that macho, I can do this, I can get this right. But clearly, he couldn't. Oh, sorry, go back to that previous slide. Can you press the backwards? We're really testing now. Other things, often conflicts of accounts, often poor epidural during labour that's been topped up unsuccessfully, poor records, questionable vital signs that I've described. Sometimes the surgery can be difficult, as we know. Lack of good follow-up on a supportive account from the partner. Now we'll have the next slide. Headaches. Headaches, we don't think headaches are very important after the dural puncture, but actually I've got 5 cases of major cerebral events, some of which have one which led to death, and some of which have led to permanent neurological deficit. But the features of all my headache cases are pretty much the same. Consent, patients are warned about the risk of headache, perceived ineptitude on the part of the person, from the patient, regarding the person sticking the needle in. So when I do an epidural, or when I do a spinal, there's 4 punctures for me. There's a little needle to infiltrate the skin, a deeper needle to infiltrate the ligaments, an introducer needle, and then a spinal needle. A patient perceives that as 4 injections, or 4 attempts even at getting a spinal in. You have to explain to them what you're doing. If you don't communicate with the patient, they just think you're not very good at what you're doing. So I've had patients say, oh, we had 40 goes. I felt 40 separate pricks with a needle. That's not good, but it may well not be 40 goes. I've often got the comment of block problems, poor communication with the patient post-discharge, discharge with a headache but without a blood patch, blood patches that fail aren't followed up, and persistence, long-term persistence of symptoms. We think blood patch pain from post-dural puncture headache goes away. It doesn't always go away. Derek's looking at his watch. Next one. I know how much Derek charges per minute as well.
Not as much as you.
Nerve damage cases, this is a typical kind of case, CSE by the trainee, side effects discussed but just a sticker with no mention of neurological damage. Pain on insertion at L12, which is pretty high. Repositioned in a different space, but the space not described, the depth of the space not described, the dose of drug that went in not described. Pain in the left calf, carry on down the list until you get to the bottom. An L5S, so that's it, L5S1 lesion, which then became chronic. So this was for a caesarean section, CSE for caesarean section, and this is what the patient says. I felt pain in my left leg with each and every attempt. I screamed with pain and begged for a general anaesthetic. The anaesthetist said, "You'll be grateful in the end, my dear." And there was no other communications. And in the defence letter from the trust said this: the anaesthetist remembers having to pause to reassure and calm your client and to reiterate the safety benefits of the technique. That fits exactly, or very, very well, with what the patient said, actually. That fits nicely with the screaming with pain and begging for a GA and the anaesthetist saying, "No, you'll be grateful in the end, let's carry on with the regional," doesn't it? It says it in other words. It's actually quite a supportive statement. What's supposed to be. Thank you. Next one. And some of these are major harm as well. So severe arachnoiditis, of which you've seen me describe in the literature. Conus damage. These are often the features. Neurologists completely unaware that obstetric neuropraxia can arise. It has nothing to do with an anaesthetist at all. It just, as soon as they see a neurologist, say it's the epidural. It was the epidural. Even if they didn't have an epidural. I've got one woman who didn't have an epidural, but they didn't. Unresponsive to complaints, perceived ineptitude, unresolved questions about the level at which the needle was inserted, and again, records and accounts often markedly differing. Just to finish really with a quick case, I divided my cases into a sort of modified national reporting and learning scheme system where 4 was very severe, an incident causing neonatal death or neonatal maternal cerebral damage or maternal paraplegia or quadriplegia, or maternal death number 5. And if you look into the way they came out, there's a few 4s and 5s in there. In fact, there were 22 maternal deaths in my series. And this is just one case, which I'll finish with. So this is a Arab 2 lady, previous category 2 section, spontaneous labour with epidural in, fetal compromise for a caesarean section, we call it a category 2 now, extension of the incision in the uterus into the broad ligament, so a bit of bleeding, epidural converted to general anaesthesia, measured 1200 ml blood loss, but a transfusion started in theatre. Delivery in 1915, baby to skaboo, a bit flat, mother out of theatre at 2030. Next slide. These charts are not in the notes. These are the charts I've compiled from looking at the notes and pulling together the various observations. So here's a chart from 2030 to 2120, which goes out of the recovery unit. And as you can see, blood pressure fine, heart rate fine, oxygen saturation fine. Next slide shows the observations from 2230 until she went back to theatre at 0110. And as you can see, a lot has happened. Heart rate has gone shooting up, blood pressure has gone shooting down. But the question to you guys is, yes, do it. Press the button. What happened in the middle? Why have we got no observations between 2120 and 2230? Any ideas? Sorry? Transfer. She's transferred. Where's she transferred to? She went to Skaboo to see the baby. So she spent an hour and a half on Skaboo, sitting beside her baby, with a neonatal nurse looking after the baby and nobody doing any observations at all. So what was actually a trend in blood pressure and heart rate was completely missed. And what the observations show is what appears to be a sudden change, but it has to change over a period of time. So in the minds of the observers, this was a sudden change in the woman's health, and they came up with a whole bunch of stuff to account for this. Let's have a look at that. I won't go through them all there, but essentially somebody came to the conclusion early on she must have had a pulmonary embolus. Sudden change in heart rate and blood pressure. Must have been a massive pulmonary embolus. They anticoagulated her. They arranged for a CTPA. They did all sorts of things, apart from thinking if the blood pressure goes down, heart rate goes up, and a woman who's had a caesarean section and bled intraoperatively, it's likely to be hemorrhage. And sure enough, it was hemorrhage. But by the time they got her back to theatre, even they decided to take her back to theatre before 0100. She didn't get back there till 0130. She was waiting for her husband to come in so she could see him before she went back to theatre. And she died in theatre of DIC. Terrible, terrible case. We do so many caesarean sections. We regard them as straightforward and routine. We take our eye off the ball. We all do this. It's not just anaesthetists, it's not just midwives, not just obstetricians. It's all of us. And that's the kind of thing that leads to a disaster. So there are 7 hemorrhage deaths in my maternal death sequence. Don't ignore those. The next slide. I think about 2/3 of the cases in which the mother dies, unsurprisingly, there is some negligence on the part of somebody. And I'll close my final slide with some misspoken comments. If you're going to get sued, generally speaking, nice people don't get sued. If you've pissed the patients off, first 2, these are both the same notes, right, written in the hospital notes. Hospital notes are, imagine, just whenever you write in the notes, imagine the patient reading those notes a couple of years later, right? You don't write that in hospital notes. No point at all. These 2 overheard comments by a patient, right? When you walk into, you go to work on duty, you are now presenting yourself to the patient and the relatives as a professional. So this is from the first comment is from an obstetrician to a trainee anaesthetist to the ODP, and the second one is the same case, the obstetrician, unsurprisingly, to the anaesthetist. But neither of those are going down particularly well. That one, after the dural puncture anaesthetist carried out the procedure, said to the other anaesthetist, he'd never done this procedure before. The impatient regarded as meaning he'd never done an epidural before. What he probably meant was he'd never put a catheter through a spinally placed needle before. But that's not what the patient heard. And the final comment is, of course, one written in the notes by an osteopath, showing the power of an epidural needle. Sudden and severe disruption to parts of the nerve supply of the right leg during one of the epidural attempts, which caused disruption of the lumbar intervertebral joints in T12. What we can do with a 16-gauge needle is remarkable if you're an osteopath. So there's one slide that just summarises things here, and these are they. Just run through them, get your record keeping right, communication right. When you go, my trust always says to us in our compulsory clinical governance thing, when you enter the hospital, you are on stage like you're an actor. I think that's really good advice. Think everything you say, everything you do will be watched by the patient and will be regarded as gospel and terribly important, however much you think it's a throwaway comment. Communication during regional block during patients, early rescue and risk management, anaesthetist not being a regional anaesthetic salesman, and clock coordination is, I suspect, something that Derek will talk about when it comes to doing crash cesarean sections. And that's my wife who put this database together in the first place, so my thanks to her. Thank you.